seizures.
He's a fellow of the Royal
So
College
how
of
do you
Physicians
identify
of
the
London
patient
and
with
the
possible psychogenic seizures? As I said, gender, history of sexual abuse, and so on. The teddy bear sign. I don't know if anybody knows what the teddy bear sign is. The young woman who walks in to see you with her teddy bear, she's 23. You know, why is she carrying a teddy bear? It's a sign of regression, right? And it is a very, very frequently observed phenomenon. Now, you have to be very careful about these things. Just because someone walks in with a teddy bear does not mean, right? And remember I said, they could also have epilepsy, right? They could also have epilepsy a lot of the time. But it's an important sign. And, you know, filming, either with a cell phone, remember you have to try and capture the onset. The onset is what tells you the most things about whether or not you're dealing with an epileptic onset or not. And it may be very protracted in non-epileptic seizures. And when the family say to you, Doc, I couldn't film it all because it went on and on and on. Think, right? Because most epileptic seizures are, in fact, very short events, 1 to 3 minutes. But it just seems like a lifetime to the family when they have to see it in their loved one. You have to do routine EEGs, of course, and the yield increases the more EEGs you do up to the fourth. But a normal EEG, of course, does not exclude epilepsy, nor does it rule in psychogenic seizures. I want to list now, and I'm going to show you a brief video in a sec with Peter's assistance. This is how, in patients who have seizures, generalized tonic-clonic seizures, you know, the major motor seizures, and I've divided it like this, epileptic and psychogenic. What's the setting? Well, it's often neutral in epileptic seizures, but highly emotionally charged because they have to do something in that environment too. Yeah, you can understand, right? Stereotypy, meaning the seizure is exactly the same each time. The event is exactly the same. I teach residents and colleagues that you must call them seizures. When a patient has a psychogenic event, it's still a seizure. It's just a non-epileptic, meaning it's not being generated by abnormal synchronous electrical discharges, but it's happening in a different mechanism subconsciously, right? It's still an ictal event. But the stereotypy is less. The pace in an epileptic seizure, abrupt onset and stop, but it's gradual onset and prolonged in psychogenic events. Tongue biting is an interesting phenomenon. When patients have a seizure, generalized tonic-clonic seizure, you inspect their tongue. With a true epileptic seizure, they often bite the lateral aspect of their tongue. Psychogenic seizures, they will bite sometimes, but they bite the tip. It's easier to bite the tip of your tongue than it is to bite the side of your tongue. Incontinence is less common, but not seen in psychogenic seizures. A TODS, remember what a TODS is? It's a post-ictal paresis, right? You see that in patients who have underlying brain disease with true epileptic seizures, but you don't usually see that in psychogenic seizures. They're not usually aware that that should happen. They're not aware, subconsciously, I'm talking about. And post-ictal confusion is actually uncommon in patients with psychogenic seizures. There is that label indifférence that patients can have with amnesia, and secondary gain is often identifiable in psychogenic seizures. Patients who have a seizure, a true generalized tonic seizure, are usually like this, slightly open, and in psychogenic, they're usually forcibly shut. The mouth is often slightly open as the patient is in the tonic phase of a true seizure, but again, in patients with psychogenic seizure, it's closed. And the only sound a patient with a true seizure makes is an initial cry as they tonically, the air is expressed from their lungs against a partially closed glottis, right? But vocalization throughout the event is more the thing in psychogenic seizures. The posture of the neck in a true seizure is a little more opistotonic or tonic, but patients with psychogenic seizures will often do side-to-side head movements. The movements are synchronous and clonic in true seizures, but often asynchronous and often associated with pelvic thrusting in patients with psychogenic events. And we talked about how prolonged psychogenic events can be. In patients with complex partial seizures, the aura is different. Patients will talk about headache or hyperventilation with associated dizziness and behavioral changes or protracted pre-ictal manifestation in psychogenic seizures. And as I said, vocalization can be complex too in these patients, and again, prolonged. Now, I want to show a video very briefly for you to see an event and to ask you whether you think this is epilepsy or psychogenic. But just so much to cover. Okay, so more or less you would have seen all the major features. Um, and you can circulate it. That, anybody has any thoughts? No, not real. Uh, True epilepsy, non-epileptic. Can I ask, well, has everyone seen it? No? Okay, well, we wait. Yeah, yeah, yeah. I should continue talking while you look at that. Video EEG monitoring, therefore, is the only way to truly define whether you're dealing with psychogenic or true, because you're simultaneously recording EEG at the same time as video, right? And you can time lock the two. And if you show that the abnormal clinical phenomenology is associated with simultaneous electrical changes, then you know this is epileptic. That is the way. I mean, there are caveats to that statement, but in general, that's the only definitive way. And that's an example of a patient admitted to the video EEG unit at Andrews being monitored. I'm ending my talk by tying it up with the behavioral consequences of all of this. You can imagine it's enormous, right? But the fundamental point I want to make is that you don't have to have all of that overt psychopathology to have behavioral consequences. Patients don't have to have psychogenic seizures. They don't have to have psychosis. They don't have to have a formal diagnosis of depression. They don't have to have attempted suicide to have behavioral consequences of having epilepsy. And it is quite challenging. And abnormal behavior has been estimated to occur in 10 to up to 50% of patients with epilepsy. Again, you can relate it to underlying brain disease or to the medications and treatment that they're on, or to subclinical electrical changes that are taking place in the brain at the same time. Peter, let me know when you're finished. Has everyone seen it? Okay. Behavior may be aggressive too, as you can imagine, after a seizure, but that may reflect confusion. And there are ultimately three questions. There are many different types of behavior problems that you can have, and they're all listed here. Mary has asked me to tie up. And as you can see, they're quite the kind of things that you would expect. But ultimately, there are three questions you're going to ask yourself. This is more or less how I'm ending my talk. Is the behavior caused by seizures itself? In other words, is it stereotyped? Does the patient get drowsy, confused, or sleepy afterwards? In other words, are they post-ictal? And what is the person like between outbursts of behavior? Are they, in fact, different, right? And not like this. Or is it, in fact, caused by medication? Did it coincide with changes in medication? Are they not eating properly anymore because of that? Sometimes not eating properly may be associated with not taking medications too the right way. I have patients who will, if they're on more than one drug, they will, all of us have seen this, they will take more of another to compensate for taking less of another, right? And these kinds of behavioral things are therefore impacting their own treatment. And is it after taking medication as an effect that you can see? And finally, is it actually independent of the seizures or medication? In other words, is it a chronic background issue, as it can be for many people? Now, how you treat behavioral disorders is entirely in the domain of people who are accustomed to dealing with that. And there are many strategies that can be used. But patients with epilepsy, I would say, respond less well to management of behavioral issues, mainly because of the complexity of the problem and the chronicity of it in the context of a very abnormal social environment that they've grown up in. I'm ending my talk with two summary slides. This is one of them. As always, when you approach patients with epilepsy or in medicine in general, a careful and very structured history is critical. The diagnosis of epilepsy or non-epileptic seizures must be rigorously confirmed. That's important for being able to give the patient best care. And you have to choose your anti-seizure drugs very carefully in the context of potential side effects and in the context of what you know about that patient's psychological makeup. And finally, I think we must do this, because unless we do this job properly, we're not going to give them appropriate and best treatment. And all that leads to is chronic ongoing disability, both psychiatric and physical, in terms of their epilepsy syndrome. Thank you. But I want to end with asking you, you've all seen the video. Epilepsy? Hands up. Oh, epilepsy. The epilepsy, anybody else? Two. Non-epileptic?